Hey everybody, welcome. I'm Janak Goyal, and in this presentation I will talk about commonly performed needle insertion procedures of knee under sonographic guide. The knee joint injection is the most common procedure of the knee. Let's first review some of the essential anatomical concepts for accurate injection of the knee joint. This drawing of the sagittal section of the knee through the intercondylar fossa shows structures which are commonly seen on the sonographic examination of the knee. In the suprapatellar region, from superficial to deep, the structures encountered are skin, subcutaneous tissue, quadriceps tendon, suprapatellar fat pad, base of the patella, and a suprapatellar recess, prefemoral fat pad, and the cortical surface of the femur. And in the infrapatellar region, you have a skin, subcutaneous tissue, prepatellar bursa, superficial infrapatellar bursa, patellar tendon, deep infrapatellar bursa, half-os fat pad, and deep to the half-os fat pad you could see the femoral condyle and the chondral cartilage. Then the structures seen on the sonographic image from superficial to deep are skin, subcutaneous tissue, quadriceps tendon, base of the patella, suprapatellar fat pad, suprapatellar recess, prefemoral fat pad, and the cortex of the femur. Based on the personal preference and clinical situation, there are many different approaches to the knee joint injection. Commonly used approaches are suprapatellar long axis scan with out of plane needle insertion and suprapatellar short axis scan with in plane needle insertion, and in plane needle insertion through the retinaculum and through the medial collateral ligament. And I have also heard of an infrapatellar approach, but I have not used it due to lack of clear definition of the structures on the ultrasound. Let's look at the suprapatellar long axis scan with out of plane needle insertion. Patient is placed supine with 20 to 30 degree flexion of the knee joint, and the transducer is placed above the patella in the long axis of the thigh. Needle is inserted just above the patella and directed in the suprapatellar recess at 90 degrees to the transducer face. The needle is seen into the suprapatellar recess to enter as an echogenic dart, and notice the filling of the suprapatellar recess indicating the accuracy of the injection. Let's look at the suprapatellar short axis scan and in plane needle insertion. Here is where I prefer a suprapatellar short axis scan and in plane needle insertion. Look at these images. Suprapatellar long axis scan clearly indicates a knee joint effusion, which seems to be a very easy target for injection. Now look at these short axis scans indicating a marked thickening of the synovial lining and a very limited space which has effusion. So needle inserted blindly will most likely get stuck in the thick synovial lining, which folds on the needle, making it very difficult to puncture, resulting in the deposit of the injection material just outside the synovial space. So carefully directed needle through a least thick part of the synovial lining with an in-plane approach results in an accurate injection of the injection material into the joint space, like shown in this image. In-plane injection of knee through medial collateral ligament provides a better pain relief in patients with a localized tenderness on the medial side of the knee joint. The patient is placed supine with 20 to 30 degrees of flexion of the knee joint and external rotation of the leg. Transducer is placed on the long axis of medial collateral ligament and a needle is directed at the junction of the medial collateral ligament and the fibrous capsule, and the injection is made into the joint just at the junction of the MCL and the joint capsule. The site of injection through the retinaculum is similar to palpation guided approach. The patient is placed supine with 20 to 30 degree flexion of the knee joint. Transducer is placed on the short axis of the medial or lateral side of the knee. The needle is directed into the joint space in plane to the transducer face. Here is your patella, here your femoral condyle, and here is your needle, which is being directed into the joint space in plane to the transducer face, which should be sitting right here, and the injection is made into the joint space. The pes anserine tendon is a common attachment to the medial surface of tibia for the tendons of sartorius, gracilis, and semitendinosus. Pes anserine bursa lies deep to pes anserine tendon between the pes anserine tendon and medial collateral ligament. Here is your medial collateral ligament, here is the pes anserine tendon, and here is your pes anserine bursa lying deep to pes anserine tendon and superficial to medial collateral ligament. For the injection of pes anserine bursa, the patient is placed supine with 20 to 30 degree flexion of the knee joint and external rotation of the leg. The transducer is placed on the long axis of the pes anserine tendon in an oblique orientation to the knee joint. The needle is directed into the bursa in plane to the transducer face. Here is your transducer, here is the pes anserine tendon, and here is the needle being directed into the pes anserine bursa. And here is your video clip showing the pes anserine tendon and the needle into the pes anserine bursa and the injection being made in the pes anserine bursa. Baker cyst and enlargement of semimembranosus gastrocnemius bursa located between the medial head of gastrocnemius and the semimembranosus tendon on the medial side of the posterior aspect of the knee. And here is your sonographic image. Here is the medial head of gastrocnemius, and here is your semimembranosus tendon and the Baker cyst projecting in a space between medial head of gastrocnemius and semimembranosus, and deep to that is your femoral condyle, and you have to see this neck of the Baker cyst to define it as a Baker cyst. The neck is located between the medial head of gastrocnemius and the semimembranosus tendon. The aspiration and injection of Baker cyst can be accomplished with many different approaches. I prefer a long axis in plane approach. The patient is placed prone with the leg extended. The transducer is placed on the long axis of the Baker cyst in a slightly oblique orientation to the cuff. Needle is directed in plane to the transducer face and inserted in the lower pole of the Baker cyst, and here is your needle being inserted into the lower pole of the Baker cyst. Here is your sonographic image showing the Baker cyst being aspirated with the in-plane approach. Here is the needle in the lower pole of the Baker cyst, and the Baker cyst clearly aspirated and cleaned.